good evening, everyone. Happy to be with you again. Today is a lucky day because we have Miss Bronia with us. Maybe with our own experience, most of you know because we have seen her in the media conference. The very day I booked her for this day. And, this is the first reference I must call because I learned from these people because, we have not worked as medical professional over there. So she can tell you exactly what is it because, NHS is the thing which is internationally approved and customized, benchmarked protocols they keep. So definitely it's authentic. So definitely whatever she says. Now the problem is you will have been hearing so many things from different places. So a lot of confusions, but I can tell you this is a reliable source. As I know Bronia for decades, I am quite sure she is the authentic person who can clarify your doubts. It is about is the speaking etiquettes and other things in NHS in the UK, which means all over the world, like not like India, but European countries, almost same standard is being followed. And NHS stands almost first in all these procedural matters. They follow very standardized and customized procedures. And I'm very happy she is here as we are reaching our anniversary. I must say, acknowledge her father and mother and her brother, sister, all of them, the family, because they hosted almost like 4 years our students free of cost in their residence, EduSkills students. Like earlier when I was in their place, it's like father, Mr. Baby, and mother, Mrs. Gracie, and sister, Blessy, and brother, 3 of them are there. Like she's the eldest. And it's always very interesting. And I used to have a lot of conversations with her regarding these things, which has helped me to help you, teach you many things. So I thought maybe having a direct conversation and direct learning from her will be very effective. So take note of the things, whatever she speaks, so that you can clarify the things. The house is full. So many others want to enter. They are in the waiting room. We can't admit them. So you will have to clarify when they ask in the platform. You will have to clarify those doubts which are being clarified today by Ms. Bronia. So Bronia, we are so happy you are here. Most welcome to this platform. This is a wonderful family we have here. It's a loving family of EduSkills. And everybody was eager since many days from the day I announced about your session. They were eagerly waiting. And even I too had a university program, but I canceled because this was the date fixed for this program. I don't want to miss it. Okay, so most welcome, and the platform is for you now.
Thank you, Father. Good evening, everyone. It's good afternoon here. So thank you very much for all the good words you've said about us. Thank you. And we were always, as I've said in the media platform, that you were always an inspiration to everyone, and always been so happy to have any contacts with you, or to always whatever you wanted from us, because you've supported us always. Like I'm sure everyone knows, that's the same sort of support you're giving everyone in this platform now. It's your mission. It's actually going very well, and I'm really glad that I can contribute as much as I can. And so thank you for inviting me here. So I think today's session, as Father has said, it's not based on OET, because you have excellent teachers like Father and many other instructors who can help you with that. But it's mainly talking from a clinical setting, how things are here. So it will give you a big idea on what to expect. So if I talk about the clinical setting here, it will give you an idea how things are here, because it's very different from what we see in India. So the nurses play a very key role here. We all work independently. We don't just listen to what the doctors say, because we should have our own rationale for what we're doing. Because you might have heard that you have to register with the National Nursing and Midwifery Council here. So we have our own PIN numbers. That's our registration number, which is individual. So if something goes wrong, we will be cut off the register. So we practice independently, and we are accountable for what we are doing. So that's why it's very important to know how things are here. So I think it might help you when you sit for OET exams, because you've got the scenarios and things which they're putting forward to you, and you don't have a clue of how the settings is working. So what I've thought is actually I'll go through the questions which was forwarded to me, and at the end, if you have any queries, I can try and answer as much as I can. I'm not a pro on this, but just I'll try and help as much as I can, or I can signpost to where to get the information from. So the first question which was asked to me was how to handle a reluctant patient. So it's mainly if the patient is reluctant or angry or however they are. I'm speaking from the clinical setting, not from a OET point of view. So if in a clinical setting you find a patient who's very reluctant or who's not cooperating or who's very angry or frustrated, the first thing you have to think is you have to have a clear mind. So you have to, you do not take it personally. So if you when they start, sometimes they might be drunk, they might use abusive words. If you start taking personally, you can't deal with the situation. So you have to think, it's just the patient. He's not well. If he's well, he wouldn't be there. So just don't take it personally and be proactive to try and see what you can do. You have to calm yourself down before you start responding, because when someone shouts at you, if you shout back, it's not a situation which can be managed later. So you have to be calm and then listen to what they're saying. Try to respect the patient, even whatever state of mind they are in, and reassure them, restate their concerns, and try and respond to their problem. If it's, for example, if it's regarding someone who's really very angry or frustrated that they're not happy with the care they're receiving, you just have to, you might have done everything what you could, but still if someone is complaining, as I said, patient is the person who has the key power here. So we have to always think that, and then you have to be very calm, and you have to listen, should be happy to listen. And you have to then, when you're talking, you have to reassure the patient, say that you'll look into it. You have to restate, just say, okay, if the treatment is, okay, I understand now that you're not happy with the treatment, or you're not happy with that none of the doctors or nurses have spoken to you about your plan of care. So I understand this has happened. I'm very sorry that this has happened to you. But let me, looking forward, let me take, going forward, what can we do with this situation? Okay, shall I book an appointment, meeting you with the senior nurse, with a doctor, or anyone? So it's just try to find a solution to say, maybe there are some situation where you are unable to handle something. There's always seniors around. There are senior nurses, managers, and everyone around. So you can just always escalate it up. You could say, okay, can I get someone else for you? Maybe I can get my manager to come and speak to you. So that's the way how you try to be calm and try and arrange it to speak to someone, to try and handle that situation. I hope it makes a sense. And then just to begin, when just to give you a vague idea of also how the situation, how the grading is working here. So when you start as a qualified nurse, when you come into UK, you will be band 4 when you're in your training role. Then you are it's banded. So the band 1, 2, and 3 are healthcare assistants, like support workers who help. So they are up to band 4 in different, if they do NVQ different courses, they can go up. So from band 5 is the qualified registered nurses. And then band 6 is the junior sister. So who's actually a bit more senior nurse, who is called as junior sister. Band 7 is normally senior sister, they're the ward managers. Band 8 is matron or high role, leadership role people. And then it is band 8A, 8B, 8C, which you would understand when you come. I think that makes a bit of, gives you a picture of how banding and how nurses are graded here. So it's just because I was talking about getting a senior nurse to review, or senior manager to come. I just wanted to you to understand that this is how the seniors are scaled up here. I think that sort of answers your first question, how to handle a reluctant patient. And the next is how to frame the sentence or open-ended questions for reluctant patients. Open-ended questions are questions that cannot be answered with just a static response of saying yes or no. So you have to further assess the patient's understanding. Then you have to start by saying, tell me more about you, or tell me more about how you feel, or talk to me about what exactly happened, or what were you doing when this happened, or tell me more about the situation. So asking questions like this will help you to, you're actually giving the key to the patient to talk. So you're actually asking them to speak to you. So, and then there are quite a lot of questions coming up, I think, which I think I will go through it later, because at the moment I have to focus on what's been forwarded to me, so we don't go on a different path and get distracted. So I think that sort of answers how to use open-ended questions. I'm sure when you go through your OET preparations, you might have known about the open-ended, close-ended questions, the need for that, when to use it, what situation to use it. There are some certain things which you have to research and find out for yourself, because there are only few tips and things which we can give, and the rest is actually the homework which you can go and do. Next is, how about introductions for the different settings known as hospital or community, school, home visit, all these settings. As I said, I will not be speaking in OET platform, OET setting. This whatever the setting is, you start by saying, hello, my name is what so and so. And you can say by, I am the nurse looking after you today. So I think whatever setting it is, that's the way how you start with the patient. Hello, your name, and then what you're the nurse looking after the patient. The next question was, how can we manage non-responding so non-responding patient? If the patient is not responding, you can ask by, hey, can you hear me? Or do you want me to continue? Or do you understand what I'm saying? Or do you want me to go slowly with you? So these are the things which because you have to then listen. You have to find out what's the reason why they're not responding. Maybe sometimes you're talking to someone older, they might not have their hearing aids on, they might have forgotten. Mostly, people when they're elderly, most of them uses hearing aids here. Maybe they don't, they can't hear because their hearing aid is not on. So you're talking to someone, if there's no response, check on this simple, because you're all nurses. So you can all understand these simple things like nursing related things, which you have to make sure that before the patient, if the patient is not responding. So are they using their hearing aid, or are they someone who, or maybe are you speaking too fast for them, or maybe are you not loud enough? So there should be different reasons why that's happening. So just try to understand always what's the reason, find out the cause. Sixth is it necessary to introduce yourself when a patient came to emergency room followed by an accident? Of course it is. It doesn't matter whatever the situation is. You always have to. How can you just be taking care of or looking after someone being a stranger? You have to have that rapport before you start taking care of someone. Even if you're lying on a hospital bed and some strangers, random strangers come and give you injections, medicines, I don't think you'll be happy. It's always nice to know the person who that are, because you're already worried, especially people who are quite old and frail. They might be worried that, because they don't know, if they don't know who the person is, or if they're in unfamiliar situation, unfamiliar persons. So you have to always try and maintain the patient, just familiarize the situations and the place and everything for them. So it's always nice to go and introduce yourself to wherever. Maybe you've started an introduction in the morning and then the person already knows you, and then you will be talking to them saying, you don't have to then go and introduce again, but you should have that rapport already. Or you can say that, oh, I've already introduced you this morning, so you know me, I am a nurse, and just start the day like that. And even if you're going to a patient who is dying, and you're going to give some maybe PRN medications like morphine for their pain, or like glycopyrrolate for if they're having lots of secretions. There are so many of these medicines which you give to them, maybe they're not responding. Still, when you approach the patient, before you give that injection, you have to talk to them. You have to say, or John or Mrs. Mrs. Bell or whatever the name is, or Mr. White, I'm just the nurse who's looking after you today. I'm just going to give you this injection. It will help you with your pain. And so that's the way how you talk to them. They might be just, the eyes are closed, but the hearing is one thing which which leaves you last. You can still hear, even if your patient is on your pathway where the patient is dying, still he'll be able to hear you, regardless of what, even if it's not hearing, it's a person. Respect the person, whatever state they are. They might be unconscious, they might not be responding to you, but you have your, you are cognitively not impaired, you know who you are. So you should always speak to them the way how you expect you speak to a normal person, to a normal patient. So that's the way how you maintain your professionalism. It's not because they understand you or they're not in a state of responding to you. Still, you always have the same approach to, regardless of whatever the situation, to every patient. So yeah, that's how you introduce if it's an emergency room. So next is in the emergency situation. The seventh question, the emergency situation. First of all, introduction and identify the patient. After the initial treatment, how to start the conversation. So if it's an emergency situation, just like a cardiac arrest or peri-arrest situation, I don't know if you're familiar with these situations back home. It's done in a very different way. Here we have this cardiac arrest team. When I work, I'm one of the persons who is in that team. So we all have our bleeps, and we get any cardiac arrest calls in our bleep. So we have to then attend the situation. We get a bleep saying cardiac arrest, level 4 PMOK, or this ward. And then you go and you hear that voice in your bleep, and then you just rush to this ward to help and do whatever you can for that patient. So you have this whole team of doctors, specialist nurses, anesthetists, ITU team, recovery team. So these are the people who are included in this cardiac arrest call. And then they go, and if it's a cardiac arrest or peri-arrest situation, you don't introduce, because the patient is already gone, like you don't have any response. So you just go, you crack on with your job. So when you say if an emergency situation, if that's the sort of emergency situation, you just go straight away, and then you start with your resuscitation process. And if the patient has ROSC, like he has a return of the spontaneous circulation, and the patient is eyes open and the patient is alert and orientated, you then introduce yourself and tell them what has happened and what you're doing. So if the patient comes around and he's quite with it, you say, oh, hello, Mr. John, or whatever, Mr. White or Bat, whatever, and say that, this is what's happened. Your heart stopped for a few minutes and we tried to do this and this, and now we are glad you're back. Okay, so now we have the ITU team here. They will assess you and we will take you to ITU. So that's the way how in an emergency situation the communication goes. I think because it's not a proper class and I can't get responses, I'm just going to talk like this, and in the end, if you have questions about it, you can ask. So that's how it's been dealt in an emergency situation. And moving on to the next question, the 8th, how to handle the stress prior to speaking session. As I've said, I wouldn't touch OET exams and things, but still generally for anything like an interview or anything, if you are stressed, what you have to do is actually you have to make sure that you arrive early, and then so you get adjust your surroundings, you meet and greet people whoever they are there, and taking deep breath if you're really stressed. I've explained it in my the other platform as well, and rehearse what you're going to say if it's possible. But if you're in the OET scenario or something, if you're getting information only then just be prepared and be calm, and I think that sort of things you just have to. It's a small, simple common tips. It's not like anything which I can do about the OET scenario though. Okay. And then next is how to start the conversation if said in the background that examination is done for the patient by you. Okay, I think the question lack a bit of clarity, but I think it may be because the patient already know you. If that's what you're asking, then yes, you can start by saying, "Oh, hi, Mr. Black. You already know me. I'm the nurse who was just examined you a few minutes ago," and that's the way you can start. So you can always say whatever you have done with the patient, or you're the nurse who just we had a chat this morning, so I'm sure you still remember me. So that's the way how you start the conversation then in that setting. Moving forward, the next question, how to start a role play with the examine. That's OET related question, which I'll skip. And the 11th question also about the interlocutor. It's actually something which is OET related, and which I will quit again. That followed by that, the next question is, which are the situations where we already know the patient? And what do you do? The question lack a bit of clarity, but from what I understand from that question, I'll answer. Maybe how you start if the patient, you already know the patient. You can start by calling the patient's name. Normally, there should be a preferred name by which by that time you might already have established, you can always, when you start, ask the patient, after introducing yourself, normally what nurses here do is they'll ask, okay, my name is Bronia, I'm the advanced nurse practitioner here, and I'm here to examine you today. And what is your preferred, how would you prefer to be called as? And that's the one thing you ask, how would you prefer to be called as? And then it might be a Mr. Blacksmith, and then he might say, or Mr. John Smith, and he must say, oh, call me John. And then you just start, followed by that, the conversation you follow is you call the patient by the name which he's preferred, that if it's John, that will be John. If there's someone called Victoria, then she might be saying, oh, call me Vicky, and then that's the preferred name to be called as. So you follow the conversation by calling Vicky. Because when you use the surname, there's always one thing which between India and England, I think we use the surname and the titles a bit differently. If you're saying the full name, you say Mr. John Smith. If you're calling just the first name, you only call John. You never use Mr. with the first name, Mr. or Mrs. with the first name. The whole name.
Okay.
Yeah, the whole, can everyone hear me?
Yes, ma'am.
Yes.
That's fine. So, so I always call the whole, if you're calling a patient's whole name, you call with Mr. or Mrs. If you're calling the first name, only use the first name. Do not add title to it. And if you're calling the surname only, use the title again. So if it's Mr. John Smith, John, and Mr. Smith. So I hope you understand the difference. So the first name alone, you never use the title, you just call just the name. If the patient wants you to be called with just the first name, then it's not Mr., it's just the name. That's a common mistake which we see always. And it's for people who are so familiar with their titles, the way they're called, they have, they feel very, they won't like it. So they have, they're very formal, the people here. So that's one way you have to always remember. Just never use Mr. or Mrs. with the first name. Okay, I think that clarifies some of it. So always find out what they like to be called. You can always ask that and just then follow what they want you to be called as. The next is, I have concerns regarding speaking. Please tell different sentences using in reassurance and empathy. So something which you could say is actually, I can see how difficult the situation is for you. That's empathetically telling someone that, oh, you understand what they're going through. So it's just making that statement. Oh, I know the whole things around you is quite discouraging now. Or I can totally understand you're upset about the situation. Or just say, oh, I know this is very hard for you to take in. So that's all if you want to speak like empathetically, that's sort of some few examples of the way how you can say. So if you're actually going to break bad news, when you break bad news, as like if the patient have stage something, cancer or whatever, if it's a new bad news, you normally, one difference from India is actually you speak to the patient, not to the patient's family again. But sometimes you can hear as well, you do get involve patient's family if they want to be there. If the patient want the family to be there, you get them and arrange a meeting. You just don't go straight away like back home and say to the patient, oh yeah, or the family that, oh, your dad has cancer, which I don't think we can cure. It's very different. You arrange a meeting. If you have you found something in the CT scan or something and you just want to discuss with them, you have to take it's a very sensitive issue because you just feel yourself in the patient's shoes. It might be quite traumatizing to you. It might just change your world in one day. That news, what you know is not the best thing to give to someone, and you have to deliver it. So just try and see the best way how we can deliver the news. So normally what we would do is we would arrange a meeting. If the patient wants the family support, we'll ask the family to be there. So we arrange a meeting for maybe like 2 p.m. the following day, and the doctor will, the consultant who's taking care of the patient will be there. The nurse who's taking care of the patient will be there, or the sister in charge. If the nurses are busy, the ward manager or whoever is a senior person. So as you can, the difference is actually it's not just between the nurse and between the doctor and the patient. A nurse's role is very important and key here because they are the one who know the patient and the patient family more, because they have more rapport with the patient and the patient family. So always here, we make sure that the nurse is present, because they're the one who can support them when the doctor breaks this news. It's just to reassure the family because they're more familiar with the nurse, not the doctor. So that's the difference. So we always try and get these people and book a meeting, and that's how we normally break bad news. We just don't go and give it harshly. So there are so many of these things which we have to really appreciate the way how things are done here, which is very different to back home. And the 15th, while speaking, struggle to find out some common words. What should I do? To be honest, I think it's more on OET, but still it's very simple to answer that you have to practice more. I don't think there's any other way how you can improve your speaking, the language, how you speak. You have to read more, you have to speak more, and you have to rehearse yourself. And that's the more you practice, the better you get. So that's the only thing which I can suggest. And how to control your speed while speaking. One good thing, very good thing is actually record your talk. You record, then you try listening to that, and then you would understand how things should be improved. It's always nice to record either an audio or a video, and then you look into it and you try to see what the improvements needs to be done. So I think just try and do. I'm not sure, that's just a tip. Because there's no definitive answers to some of these questions. And also then watch when other people talk. You have lots of videos which you can watch, and then see how they pace it, how slowly they're going about it. So then you understand. I think there's also someone was saying about like, taking a sip of water in between. So there are many techniques, but always try and record something and watch, and you can improve. I think that's helpful. And is it necessary to address the patient like Mr. or Mrs.? I think I've already explained that earlier, that how to use Mr. and Mrs. and also about a patient's preference, how he like to be called. And if the interlocutor acts the father of the patient, but that's again an OET-based question, which I'll skip. Next is, if the patient is not convincing after the clear explanation, what will I do next? In a hospital setting, if you are unable to convince a patient, you then escalate it up to a more senior person. You always have help here. Nobody expects you to do everything to manage everything by yourself. There are seniors who can help you and support you. So the main thing is actually escalating it up. Instead of escalating, if you just don't bother about it, it can raise into a complaint, and then you have to answer, write explanations and quite a lot of things. So it will go a bit out of hand. Always the better thing is actually you say, the patient is asking something, whatever you're talking to him is not making sense to him probably, or he's not taking any of it. And you can always say, Mr. John Smith or whatever, do you mind? I can just get a senior person for you to speak to you. You know, we all wear different uniforms depending upon your banding, and the patients are very familiar with that. The minute the next uniform comes, they're happy. They'll be more than happy to listen to whatever they say. So that's something which always fine. There's nothing to be upset about it, but always escalate it up, and the problem will be theirs then. And always there's a way of dealing. More experienced people can deal with it more effectively. So escalating is very good. And next, which words should we avoid while speaking, like judgmental words? There are something called as filler words, which you use like, yeah, like all those things. It's just more like you cannot frame a sentence. You're actually quite lost, or it takes the eloquence of your presentation or the effectiveness of your communication away. People will start getting bored if too many hours and oofs comes up in between a conversation, which means they might think you don't know what you're talking about. So try to avoid those things, like something called as filler words. You can just Google search and find out what they are. And then non-judgmental words they're asked. It's always very important that a nurse be non-judgmental, because we have holistic care. That's what we provide here. So we include patients' mental, physical, spiritual health. So we have to be open, we have to be transparent, and we have to have a good heart to listen. So it's not a speedy process as we do back home, where we go and speak to the patient's family, just say that, yeah, oh, your dad, I'm just going to give an injection to your dad. No, you're going to give the injection to the patient, speak to the patient, because if he's been injected, why should his son know about it? It should be him who should know about it. So it's very important that sort of. So, and also if the patient want to say something, if you're being judgmental, how can they be open to you? Communication, although we've learned when we are doing our nursing, it was the fundamental of everything. When we learned, it was all in papers back home, and I didn't understand the communication was so important until I came here. Because you speak every minute, you speak to the patient here. Communication is the key factor. Because you have to speak to everyone. When you're working in a hospital setting, you have to you begin the day by communicating with the nurses who worked the previous shift. Your communication starts there. You get a handover, then you start going and introducing yourself to the patients. You talk to them. You talk to them about, if you're going on a day shift, ask them about how the night was, what they had for breakfast. Are they eating well? Have they got any concerns overnight? Did they have any other problems? Are they worried about something? So these are the things you have to ask your patients. So then the doctors come in, the physiotherapists come in, the occupational therapists come in. There is social workers if there is something involved with the social work issues. Like if the patient, there are quite many of the patients who come here is elderly. So these elders if they come, they might be living on their own, because it's the cultural differences is quite huge between back home and here. They normally live independently. None of the children live with their parents. It's very rare. Once they're 18, they go out of the children are 18, they move out of your house. That's the system how they are, and then they do everything for themselves. So these parents will be living, children might ask about them, or they'll be involved in the care, but they don't live with their parents. So the parents will be on their own. If they come with a fracture, come with a fall, and then they have a fracture of the arm or leg or whatever, how are we going to send that patient back to their own home? Maybe they have upstairs, their bedroom is upstairs. And if he has got a fracture of the leg, and after the surgery, when you're sending the patient home, how are they going to reach upstairs to their bedroom? So as nurses here, as I said, we provide holistic care. So we have to know about all these things. We just don't, we can't discharge someone. So it's the nurses who should refer to social services, so they can arrange to see if the patient needs care package, like if they need a carer to come and wash the patient and dress the patient in the morning, or if we refer to occupational therapists to see if they can arrange the bed and the settings in their downstairs in the house, so the patient doesn't have to go up. So, and the physiotherapist to ensure that does the patient need a frame or whatever to actually go home with. Maybe they won't be able to just walk up. So these are the things which you have to consider, but all these referrals is done by nurses, not by anybody else. So that's why we say the nurse plays a key role, and your communication is very important, because you are the one who is identifying all this. Why do you think you will identify? Because you communicate with the patient, you communicate with the patient's family. So they might all have concerns. So you have to, you ask them whether they live alone or how are they, the family setup. So you actually know your patient in and out. So to send them home, to make their discharge safe, you have to make sure that all these things are in place. If the patient can't walk, you have to make sure that they have got enough downstairs bedroom. They've got carers coming in twice or 3 times a day. So you don't have to, you're not the one who's deciding how many times the carer has to come. That will be done by the social services. They do their assessment and they plan all those things, but you are the one who initially gives the referral. So that's where that's how important the role is. That's the way how you communicate. And that's why I say it's a holistic care. It's not just about just the disease or what they come and the treatment. It's very different to our concept of nursing back home. And it's a very different perspective here. So I think that gives you a clear picture of how things happen here, the OET based. So I think I've almost answered most of your questions. So now I think it's back to you for, if you have any questions, I can answer them.
Thank you, Bronia. Great indeed. 40 minutes continuous. Oh, yeah, it was a packed, information-packed session. And, my friends over here attending this session, she has done her graduation, post-graduation, everything in the UK, and she has 19 years of experience. So I think you have got clear picture about many things, about task completion and all. I'll discuss after, once your Q&A is over. I will answer a few of the questions. You can ask me as well. And maybe a slight difference, what we mean in OET. Other things like whatever she said, I can tell you that is the thing, exact thing, and make it sure that is the right thing. And you do not search again for clarifications. And if there is some slight changes like task completion and all that, which or whatever the question she has skipped, we will deal with it after this, after the Q&A. So you can definitely ask her those things, and like Mr., Mrs., and first name, second name, all those are the common things all over in Western countries, the common criteria being followed. So if you have any questions, you can unmute and ask. Maybe 1 or 2 questions were in the chat box. Let me check. Yeah, patient talk totally unaffected. We'll come back to that. That is OET question. And there was something about, okay, assumed patient's name without. Okay, that I will answer later. Assuming patient's name, that I'll come back to that. Yeah, you can ask any of the questions.
Somebody has asked about PhD.
Yes.
If it's actually whatever you do, if you don't have an NMC registration number, PIN number, you won't be able to work. So you have to always start with getting a registration for Nursing and Midwifery Council, and you start as a Band 5 nurse here, and then you move on to your whatever it is, because the PhD back home they won't accept it here, unfortunately. So I think it is wherever you've learned, it's it's your master, if it's your degree for yourself. But I think there are certain ways where you can do. There's something called UKNARIC where you used to you check the equivalence, how equal is your studies to what in the UK equivalent of whatever you have learned. So it's called UK NARIC previously. I don't know what it is now, but maybe you can just Google search and find out. So they try to give you, if you feed in all your, whatever you have done, your qualification, then they will say that what is it equivalent to in UK.
Definitely we'll see that we can keep one more session in Malayalam if Bronia has time, sometimes later. That
No
will
problem.
give you more, you will become more comfortable. Some of you will be very comfortable with that. And also we'll think of a session with interlocutor, OET interlocutor and Miss Bronia later on as the time permits. She has promised me a support for our family. So